Hello, everyone, and welcome to today's live broadcast, Pharmacogenetics and Psychology, presented by Dr. Daniel Mueller, head of the Pharmacogenetics Research Clinic at the Campbell Family Mental Health Research Institute at CAMH, and associate professor in the Department of Psychiatry at the University of Toro. I am Xavier Gutierrez of LabRoots, and I will be your moderator for today's event. We're delighted to bring you this educational web seminar presented by LabRoots. LabRoots is the leading scientific social networking website and producer of educational virtual events and webinars. Before we begin, I would like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. Just click on the Ask a Question box located on the far left of your screen and type the questions into the drop-down box that appear on the screen. We'll answer as many questions as we have time for at the end of the presentation. If you have trouble seeing or hearing the presentation, please click on the Help Desk button located in the promotional board at the bottom and/or center of your screen, or use the Ask a Question box to let us know that you're having a problem. This presentation is educational and thus offers continuing education credits. Please click on the Continuing Education Credits tab located on the top right corner of the presentation window and follow the process to obtain your credits. Please join me in welcoming Dr. Mueller. I will now turn the presentation over to him.
Hello. Thank you very much for this nice introduction. My name is Dr. Mueller. I am a staff psychiatrist at the Center for Addiction and Mental Health in Toronto. We are Canada's largest mental health center. I'm a professor at the Department of Psychiatry and have a secondary appointment with the Pharmacology and Toxicology department. My area of research over the past 2 decades has been to improve medication treatment in psychiatry by using genetic information, which is commonly referred to as pharmacogenetics. And I would like to briefly talk about the complexities in psychiatry and perhaps also why we have difficulties in finding the right medications and why genetics can hopefully help us to improve that considerably in order to give the best treatment to our patients. If we look at psychiatry, and I'm trying to here we go. I'm trying to show you some of the common psychiatric conditions that a psychiatrist can and will encounter typically during their work. You can see quite a number of conditions here listed by the typically used DSM-5 criteria. And you can see that it involves neurodevelopmental disorder, for example. Then we have all the spectrum of psychotic disorders and schizophrenia. We have bipolar disorders, depressive disorders, anxiety disorders, OCD, and many, many more. And I was myself surprised, I must say, when I was when I was in med school and when I was a student. I really believed that psychiatry is a niche area where most people will not get, will not have to deal with, and it's a rather uncommon situation. But that definitely is not true. People just don't talk about it. There is a lot of stigma, and those people who are really severely ill, obviously, are treated in hospitals and anywhere else, and you just don't see them as much. However, it has been estimated that about 1/3 of the population, so that's 1 out of 3, will at some point in their lives encounter a psychiatric condition. And if you think about that, and even if it's only 20% maybe, if you're really strict on your criteria, that means 1 out of 5. And that means that basically every family has at least someone affected. Every family, including second-degree relatives, if you wish, has at least one affected by statistics. So that means everyone actually in our society is likely to interact, even on a family basis, but also maybe at work and anywhere else, two patients or two people who suffer from mental disorder. So it is very common, actually. And that should be kept in mind because it also reflects the high prescription rate of psychiatric medications in the community. And for example, in Canada, I just saw a recent statistics where the medication which is mostly prescribed to women, number one, are antidepressants. And I was very surprised to see that myself. I wouldn't believe that, but apparently that's how it is. So, and in certain ways, psychiatric conditions are spectrums. It's not always, again, easy to draw a line who has treatable symptoms or not. We still can do a much better job, certainly, in also understanding psychiatric conditions and defining them and finding perhaps new ways of diagnostics like biomarkers and so on. But again, today, this is all about treatment. And last but not least, we also have complexities in terms of what we call personality disorders. Personality disorders, which, believe it or not, might be also, often require medication treatment. Among them are things like borderline personality disorders, schizoid personality disorders, and whatnot. These are milder, if you wish, sometimes. Sometimes they can be a bit milder conditions than the full disorder, but they sometimes can also be by themselves highly problematic and associated with lots of self-harm and so on. And here sometimes, again, we cannot, even though these conditions are typically best treated with psychological interventions, psychotherapy, and so on, we sometimes cannot avoid using medications in order to alleviate some of the most acute symptoms. However, what are these medications about? And it's been now known for some time, for decades, that our brain has two major neurotransmitters. And one of those are the dopamine pathways, and the other one are the serotonin pathways. And they do a lot of things, dopamine and serotonin. Sometimes we get simplistic ideas about them, dopamine as being the pleasure hormone and serotonin being about happiness and so on. It is a bit more complex than that. But however, we can certainly see that most of the medications which are prescribed, particularly for psychotic disorders, which would be antipsychotics, or depression and anxieties, which would be antidepressants, most of them typically target broadly either dopamine pathways or serotonin pathways. And by doing so, they often achieve, you can often see that they achieve some good results in terms of the symptoms that patients are complaining about. However, it should be still seen as a kind of broad intervention. It's a little bit like, in infectiology, it's when you really don't know, for example, what the germ might be, you give one of these broad antibiotics, and you basically kill a bit everything, and you will also hit then, of course, you will likely hit also the germs, the bacteria that you would like to hit because they're causing the problems. But it's a little bit similar to that. So with these medications, we're still a bit bulldozing in a certain way these pathways, which again sometimes then also cause side effects which we don't like, and patients certainly wouldn't like at all. And you have to balance that often. You have to really balance what is a lesser evil now here, to use medications or to not use medications, and how to use them, and how to do this with the least side effects. And the good thing is newer medications are much more selective than older medications, and newer medications often are much better tolerated and also come with less side effects and so on. However, they still mostly target these two pathways. Particularly the medication I'm going to talk about today, which are antidepressants and antipsychotics, mostly target either or these two pathways. And that is good in a certain way that we have the medications, but again, we have not been successful, even though these pathways have been known for decades now. We have been at least little successful, let's say, to target psychiatric symptoms by finding how to be perhaps more selective and perhaps even target other pathways which might also be important. There has been a lot of research done now, unfortunately, however, because of the complexities of the brain, because of the heterogeneity of symptoms and so on, we're unfortunately not there yet to offer, really advanced medications. And that's where we will then have to turn again to the shelves that we have today and see how we can do the best or treatment, how we can select and basically find the best treatment by the medications that we currently have. And I usually like to start my presentations with a famous quote from Sir William Osler, who was a Canadian physician and who was the first who published an encyclopedia about all medical conditions and treatments back in the 19th century. And he once said, if it were not for the great variability among individuals, medicine might be a science and not an art. That's a bit surprising, perhaps, because we all believe, of course, that our treatments are very much based on science and on research and on data, on evidence-based medicine and so on. But the reality often shows that no two patients are alike, and even though they present maybe with the same symptoms, you would think they might then benefit from the same treatment, but that is not often the case. You have to basically become a little bit creative, a little bit, ready to see variations and to see one patient's improving without side effects, the next patient might improve but has side effects, doesn't want to take the medication, and then patients who might not even improve and have only side effects, and then patients who where nothing really happens even after 6 weeks of, let's say, antidepressant treatment. So here you have to become a bit creative. You have to look into sometimes into really combining perhaps medication, augmenting medications with other agents and so on. And that is complex. That is difficult again because you never know the outcome up front. And of course, it makes it a bit look like a trial and error approach, even though I believe we should be careful by saying trial and error all the time. But definitely, it is a bit like you become a little bit creative, and you cannot always find answers in the books. However, what is variation? What is it coming from? Why do people show variation? And do we know nothing about it, or do we know something about it? And if we look at variability in medication outcome, we know at least a few things already, which are definitely important in dosing, in terms of side effects that we might see, and so on. And that is certainly age. So we would not treat a child similar to, let's say, an older adult. We know that gender matters in terms of dosing, in terms of potential side effects, perceived side effects, and so on. There is also the area of sexual dysfunction here, which can be important. Then there is ethnicity. That is also an interesting phenomenon, particularly in a more and more diverse world, that some people from certain ethnic groups, and I will give you examples later on in my talk, might just not tolerate medication because they have different genetic variations in their drug metabolizing enzymes, for example. And so that is one other reason. Another one is symptom profile, and what I mean by that is basically that there are many ways of how people can present when they have, for example, depression, or when they have schizophrenia. Some people in schizophrenia hallucinate more than others, some don't hallucinate at all, and so on. And in depression, some people oversleep, some people have insomnia problems. So obviously, if there is such a heterogeneous condition, it's hard to believe that one and the same drug will take care of everything. It certainly makes a big difference. And imagine also people maybe getting depressed because they have been traumatized. For example, it's hard to believe that any pill will then take care of the problem as well. You might just want to know about some traumatization when you treat any patients with depression, because then you would also need to tackle and start to treating traumatizations in the past. So this is an example of what I call symptom profile, or symptom manifestation, the type and the severity of it. Then, last not least, we have drug-drug interactions, and that's particularly important because many times if we add a drug to existing drugs, or the other way around, if drugs are added to our psychiatric drugs, there can be now drug-drug interactions which can sometimes exacerbate new symptoms, new side effects, and so on. And so the patient comes to see you. It's very important to also rule out any drug-drug interactions, and so even with over-the-counter medications. St. John's wort has been taken by many people over the counter and is supposed to alleviate depression, and it does so also. But however, unfortunately, it interacts with drug metabolizing enzymes, the CYP3A4 one, which then can cause problems elsewhere. Mainly, it basically can, for example, make other medications ineffective. And in the UK, there has been a report that at least, believe it or not, 20 babies or so were born, even though their mothers were on contraception, but by taking St. John's wort against depression, which is, again, natural medicine, the contraceptives were not working any longer, and therefore these mothers became pregnant. So if you wish, this side effect here could be to have a newborn, and it's not meant ironically or something, but it tells you about the importance of also checking for drug-drug interactions, including over-the-counter medications. And finally, genetic variation. We're convinced that genetic variation is going to tell us a lot also about this variability that we do see in the response to medication. That's why we're doing this research. As a group, as a field in genetic research, and it's an increasingly number of researchers and publications and larger projects which are now developing and so on throughout the globe. Because yes, it is very promising. It's a very promising approach and can ultimately help many people and save a lot of money. Coming back to science, if you look at the publications that are out there, we can typically distinguish three types of studies. So in order to go and to take you through the studies of pharmacogenetics and psychiatry, perhaps it is important to also go through those three domains as they are typically published. And the first domain are the so-called drug metabolizing enzymes, where studies are conducted in genes which are known to either affect absorption, distribution, metabolism, or excretion of certain drugs. And those genes show variation, considerable variation at times. And so here we have a good reason also to believe that we would expect good results from such studies. Then, of course, there is the alternative is to look at your patients, how they respond on a certain medication, and then you do a genetic test afterwards and examine which genetic variations were associated with a certain outcome, mainly improvement, and maybe which symptoms and so on. Here, the problem is a little bit that sometimes, however, response to treatment remains a bit difficult to measure, starting from the problem that people have different symptoms, so they can also improve in different symptoms. So you have a lot of variation here, and that makes it sometimes difficult to really have a good judgment on how effective drugs have been in certain areas versus others. So there can be confounders here, and therefore these studies are a bit more, if you wish, difficult to manage and to interpret. whereas with drug metabolizing enzymes, we can often measure drug levels very precisely, and that would help us, for example, to understand the impact of genetic variation. Finally, we do have a third category, which are side effects, and here, often enough, we have the chances also to be very precise in measuring the type of side effects, for example, weight gain induced by psychiatric medications. And therefore, this can be another independent, distinguished category to conduct studies. So that is what the field is about in terms of studies. And now, here, this is a little bit of pharmacology, basics pharmacology. You can see left pharmacokinetics and right pharmacodynamics. And basically, every time we take a pill or a drug, it goes through our intestine, it goes through our blood system, and so on, before it reaches the target organ, which in our case is the brain. And while it passes basically the intestines, the kidneys, the blood, and so on, the body is typically working against elimination or cracking down, metabolizing the medication, and that's what's called pharmacokinetics, basically what the body does to the drug. At the target organ, in our case, mostly the brain, this is called pharmacodynamics, basically what the medication then does to the body. And we can imagine that because these are two very different compartments, as a pharmacologist would say, we can imagine that we can also use these distinctions in our pharmacogenetic studies, which in fact we do, and we can say already at this point of time, not as a spoiler maybe, but that pharmacokinetics has really shown to be largely determined by genetic variation, which we can at this point also measure quite well. So you're going to hear more about pharmacokinetics now because this is really where most of the studies have been conducted with most promising results. Going deeper into details or drilling it a bit further, what are these drug metabolizing enzymes? Well, there are many of them, but I think that this pie chart here gives you an idea about the relevance of certain drug metabolizing enzymes. For example, you can see here on the left, CYP2D6 has a huge proportion, which means in this case, the pie chart reads like CYP2D6 is much involved in many of the psychiatric medications. It is, however, if you could now imagine, another pie chart in your mind, it is, however, only present to a minor fraction in the liver. Therefore, it can run out of capacity quite quickly if you overwhelm your CYP2D6 system. So that's why we say it has low capacity, but it also has high affinity, which means medications which are primarily metabolized by CYP2D6, they have to get metabolized by that enzyme. They cannot get metabolized elsewhere, and therefore we have a bottleneck situation here very much with the CYP2D6. So it's a very critical gene. We will keep in mind for now. Then those other ones, CYP2C19, for example, CYP3A4, are equally important, but the situation might be a bit more different here. CYP3A4 is much more abundant, so it's much more difficult to, for example, cause problems here. But CYP2C19 is another example of a gene where we see significant amount of variation and also a significant amount of medications being metabolized. So this gives you an idea about the enzymes we're looking at. And I typically like to give you an example about a case report. I like to do this because it tells you really the importance of one single enzyme and how it can really determine very critical situations or can be involved in actually life and death. Because this is unfortunately patient back in the 1990s. He was a 36-year-old male with depression. He eventually lost his job. He went into a marital breakup, and he was first treated with amitriptyline, but then the doctor decided to add a new medication at that time, Prozac or fluoxetine, on top of that. And 6 weeks later, this patient was found dead in his apartment, and they measured they measured the blood concentration of drugs, and they found an excessive level of amitriptyline, and that was then speculated by the coroner that would have caused the death, and that this was done intentionally, and therefore the cause of death was determined as being suicide, which in depression, unfortunately, is not unusual, particularly if you have further existing stressors like losing your job, losing your spouse, and so on. However, the life insurance now wouldn't pay anything, and the ex-wife therefore requested further analysis, being convinced that this ex-husband of hers would not commit suicide without even leaving a note or anything. And luckily, she found someone who looked into it in details, and Sheldon Prescorn was involved, the author of this case report, who could in fact show that this intoxication has happened because the second medication, fluoxetine, has inhibited the CYP2D6 system. It has basically, if you wish, overwhelmed the CYP2D6 system to the point that amitriptyline, which is also metabolized by CYP2D6, could no longer be properly metabolized, and therefore it accumulated over time. And over 4 to 6 weeks, it was in fact calculated that you would reach levels which are highly toxic, which typically end in cardiac arrest. So in this case here, because of this second drug, it was now a drug-drug interaction. It was basically an accidental overdosing, and when fortunately with lethal consequences. However, the point here is obviously that it wouldn't have been detected first at all if a second look wouldn't have been taken. But the point is that you can see that this enzyme alone can cause a lot of issues if it's not running, or if you don't allow, or if you have anything in your system which makes this CYP2D6 not working well. And interestingly now, there are people who are born actually, about 5% or so, 5 to 10% among European patients at least, who are born with no CYP2D6 activity. So basically it is as if they would take fluoxetine since birth, and we call them the poor metabolizers traditionally. We can also call them no metabolizers if you wish, and this is shown here in this graph. This is a graph of Andrea Gadik, and it's important. Andrea Gadik is a colleague from Kansas City who has basically devoted her lifetime research to that enzyme alone, and she has brilliantly shown many times how genes can, or genetic variations of that gene can influence expression. And so by the means of the current classification of metabolizer status, we have rapid metabolizers on the left, the normal metabolizers in the middle, we have slow metabolizers with some impaired metabolizing system, and then we have these poor metabolizers on the right, who basically do not have any CYP2D6 activities based on genetic variations, basically genetic variations over time. And you can see two things here. Basically, most people have a normal functioning CYP2D6 system, so that's good news. Most of the time, if people will get a medication primarily metabolized by CYP2D6, they will not encounter any problems. So evidence-based medicine at this point could say, well, most people do well. If we have 100 patients, at least 80% or so, 75 maybe, will do well. So evidence-based medicine is going to tell you you can use this drug, and just be careful. Not everyone will benefit maybe. However, the vast majority will. Now, personalized medicine and using genetic information, however, will allow us to preemptively screen for those people who might get in trouble. And that's the difference between, if you wish, evidence-based medicine and precision medicine. Because genetic variation can very nicely, at this point of time, distinguish and identify people who are outliers. particularly at the far left and at the far right, as in this case. And by doing so, you can avoid a lot of troubles, you can imagine. And I'm going to give an example of how much importance these metabolizer statuses can be, for example, in this medication here. This paroxetine is one of the first so-called SSRI antidepressants. And you can now see here, that if you are a rapid metabolizer, if you have a system which works extremely well because you have copies actually of your CYP2D6 gene, so you have copies for whatever reason, your body has created copies of your CYP2D6 sometime in history, and you're just inheriting it now from your parents and so on, then you can see that you can extremely efficiently metabolize paroxetine here at the bottom. You almost do not get any therapeutic level, even if you take a higher dose of paroxetine, 40 milligrams. Now, the extensive metabolizers or the normal metabolizers are those in green here, and they typically reach a therapeutic level at 40 milligrams. However, intermediate and poor metabolizers now can be in big problems because they will achieve much higher levels, which can be toxic for them. So if you dose someone with a CYP2D6 poor metabolizer genetic constitution, it can cause problems. They will probably have side effects, and this tells us the importance again about this enzyme alone. I would, however, also emphasize that there is a lot of ethnic variation for these CYP2D6 metabolizer status. So I've shown you that about 5 to 10% of the Europeans are here on the right, are poor metabolizers in red, but there is about 20% of East Asians who are so-called intermediate metabolizers, but what it means is they have a slightly impaired CYP2C19 system, and CYP2D6, and that means that they can basically they can also show more likely issues at normal doses of medications, right? And then, interestingly, about in some areas in Africa, they found 40% of Africans being rapid metabolizers for 2D6. That likely has also probably had evolutionary advantages. You can imagine that CYP2D6 has not been created by nature to metabolize antidepressants, but you can well imagine that CYP2D6 has basically evolved as a way of detoxifying venoms or detoxifying anything which is toxic to your body. And if you now are more exposed to certain venoms, or maybe it could be fruits or whatever, where you have toxic products, having a very efficient CYP2D6 system has probably shown to be of benefits, and therefore these in this particular area there has been selective pressure towards CYP2D6 rapid metabolizer status, and now 40% have these rapid metabolizer status. And as you can imagine from the slide that I showed you before that, you will then see much less effects if you treat someone, for example, with paroxetine, until you might know that someone is a rapid metabolizer. You might just never get into therapeutic plasma levels. And that's very much true also, and that has been shown much of the times. And then finally, for example, for CYP2C19, just to mention that briefly, there is also a big difference between poor metabolizers, which are much more common in Asians than in Europeans. So again, here, medications which are metabolized by CYP2C19 will much more likely be problematic for Asians, East Asians, than for Europeans. Okay, and this just gives you basically another idea. You see these pie charts have very different colors, and what it means is this is again about the CYP2D6 system in different areas of the in different ethnic groups, and basically you can see by the without going here too much into details, but you can see that the colors are different, which means that certain genetic variations are much more likely or unlikely to occur depending on your ethnic background. So it is a complex, very complex gene, because you also have to now take into consideration these variations when you interpret studies and recommendations, just to keep in mind. So now, what are experts saying? Expert groups who are, evaluating these genes and these gene variants and medications, and typically these groups, these reviews that are written on pharmacogenetics and psychiatry, will typically look at three things: analytical validity, clinical validity, and clinical utility, just to mention them. And analytical validity is basically really, do you have the proper tools in hand to measure genetic variation and to understand, the complexities of a gene. And yes, I guess we have a very good understanding of genes, and we have very good labs who can also do that. However, we're still in research. Research is still progressing to better understand the function of these gene variants on the gene itself and how they interact with each other. Then we have clinical validity, which basically is really, can a gene variant be associated with a certain outcome, yes or no? And that is, of course, the question we all want to know. Does it really matter, if you wish? And ultimately, clinical utility addresses things like, is it really ready for the clinic? Can you really now go and should you go and offer genetic testing, for example, for everyone? Because you have other factors here involved as well. For example, economy. Is it already clear that by testing everyone who comes into your hospital that you will at the end also save money, for example, right, and so on. So these are questions which are also addressed, but sometimes with varying degrees among expert groups. Now, I've been working, and it's been a big pleasure over the years to work with the Clinical Pharmacogenomics Implementation Consortium, which is one of these expert groups which basically go through the whole entire field of medicine, not just psychiatry, and are evaluating constantly which gene-drug pairs are actionable, which means is there enough research, are there enough data to pick up a gene and see how it relates to certain outcomes to any kind of drugs, but including also psychiatric drugs. And the Clinical Pharmacogenomics Implementation Consortium is independent of any, I would say, pharmaceutical companies or biotech companies or so on, and they use quality criteria from the Institute of Medicine, which are listed here, which is basically the top standard you can have if you really want to evaluate objectively the impact of certain gene variants or pharmacogenetics in general. And so they have started to do this now for many years, and again, we've been looking at some of the most important actionable gene drug pairs in psychiatry together. And here is an example of how a recommendation would look like. So this is a paper that looked at the effects of CYP2D6 and CYP2C19 you've heard about, and on dosing of tricyclic antidepressants. So first generation, if you wish, of antidepressants are called tricyclics. And as you can see here on the left, you can see that the metabolite status is listed in 4 categories, and on the right, you can see the level of recommendations, which was felt to be strong, which was the maximum highest label you can get. So basically saying that yes, if you do know your genetic constitution, if you do know your metabolite status, which is either one of the 4, and do you do something about it, or are we recommending to do something about it in the clinical setting? And the recommendation was strong in 3 out of 4, which means yes, we would highly recommend to consider that genotype constitution, that predisposition, if you want, whenever you now go and use and prescribe tricyclic antidepressants. So very convincing arguments in terms of the science behind that recommendations. And currently, we have published, again, over the past years, we have published 3 reviews which looked at tricyclic antidepressants, again, 2D6 and 2C19. There was another one on SSRIs, which are the newer antidepressants like citalopram, widely prescribed, sertraline, widely prescribed, but also paroxetine, fluoxetine, and so on. Again, with 2D6 and 2C19, and another one which is carbamazepine, originally developed as anti-epileptic, but has been shown to also have beneficial effects for bipolar disorder, for example, but also for some pain conditions. And so carbamazepine, however, can have a very, very severe side effect called Stevens-Johnson syndrome, which has mostly been observed with East Asians, and it has been shown that these East Asians have a certain gene variation, which is called HLA-1502, and so in some countries, in some areas in East Asia now, before carbamazepine is prescribed, it is mandatory now to look at this gene variations, and that again has been reviewed by our CPIC team, and you can find these recommendations in the publications. In progress or in consideration at this moment is atomoxetine, which is an ADHD drug, and again CYP2D6. The classes of SNRIs, another class of antidepressants, again with CYP2D6 and CYP2C19 is being considered. Antipsychotics also do have often CYP2D6 at their primary metabolizing enzyme, so it would also be interesting to look into that. And finally, there's a gene in the blood-brain barrier called ABCB1, which transports, or it's an efflux protein, which basically regulates the concentration of certain drugs, including antidepressants and some antipsychotics, in the brain tissue, and that is another probably actionable gene-drug pair that should be considered for further review and evidence-based reviewing by experts. Okay, what does the FDA say? Now, we have heard about the importance of these genes, and what would the FDA, for example, say? And I've listed here what the FDA would currently say, for example, for CYP2D6 poor metabolizers in antidepressants, or for antidepressants on the left, and you can see that for all these drugs here, all these medications, these are all antidepressants, also relatively widely used, some of them, where they say, well, wait, if you're not a normal metabolizer for CYP2D6, you might get into problems. You might want to adjust the dose. You might want to take something else, and so on. But you can see the list is quite long. So the FDA is actually already recommending, if you know your genotypes, they say, basically, if you know this, then you should do something about it. They don't say you should get tested. That's not the point. They don't say where you can get tested. That's a different story. But they basically tell you if you know it, you should do something about it. They list also 6 antipsychotics where it should be, where it would matter, and a few other medications like psychostimulant, modafinil, and so on, where you would have strong recommendations potentially to change your plan if you knew your genotype, right? And someone has now, and sometimes I do say that if you are a poor metabolizer, you should really use this as a very critical clinical information. It should be basically labeled in medical reports, discharge summaries and whatnot, as almost like as if you had an allergy. Let's say you would recommend this information to be propagated in your medical records, so that future caregivers will be aware and can do something about it once you got tested. The good thing is, once you get tested, once you know that you're a poor metabolizer, you know it for the rest of your life. So it's a one-time only test you need to do in order to protect you against a lot of medication that you might encounter throughout your lifetime. So it looks like it would be a reasonable thing to know your CYP2D6 metabolizer status, and if it's not normal, to actually label and flag at any time you're prescribed any sort of medications. So, and someone has now done a nice job here. This is Chad Bausman's paper in Lancet Psychiatry, and which is really nice to read because it has shown a little bit also what is out there in terms of opportunities to get tested, which companies would typically be around and offer this kind of testing, but also shows that companies tend to include many genes sometimes in the tests where the evidence level is not as good as for CYP2D6 and CYP2C19, which you can see on the left bottom here. You can see there about 6, 7, or 8 genes where the evidence is really strong, and then with going down, the evidence becomes lower and lower and lower. But companies might still feel inclined to also add those genetic tests. But all of them typically do include CYP2D6 and CYP2C19, which is shown on the right graph on the upper half. You can see that 100% of the companies all include CYP2D6, CYP2C19, because that's really where I guess most of the evidence is out there. However, we still see a lot of things going on here in this area in the commercialization of genetic tests, and still, however, I would very much advocate to look into thoroughly comprehensive written reviews. Because unfortunately, what happens is that sometimes if tests are being offered and they are, based on, where some genes are based on poor evidence, people tend to brush away the whole test and think that the whole test isn't working or is not ready yet. And this negatively affects the field of genetic testing for those genes where it would be actually really important. As I showed you, 2D6 and 2C19 would be would be those among them, and maybe HLA also for Asians. And here we have, again, we need to really encourage everyone who works in pharmacogenetics and who is making statements towards clinical application to really choose among the good reviews and those who are really based on science and data, again, like such as CPIC reviews or something like that, in order to make proper conclusions. Okay, and last half of the talk here, basically, I'm going to tell you briefly a little bit about what we've been doing at CAMH here in Toronto, because we have been feeling that it would actually be important to provide genetic testing to our patients, and did that starting in 2009, when really no one else except 1 or 2 clinics, such as the Mayo Clinic in the U.S., for example, would have started to do this genetic testing to improve treatment. And we started in 2009 with a study which is listed here briefly, and this is a flow chart of the study. We have encouraged every patient who was treated here to be enrolled in our study, and would then follow up the results of the genetic testing with them and their physicians, and would then also want to know, first of all, if it's a feasible thing to do, if it's accepted, if there are maybe misunderstandings potentially in terms of what these tests can do. And so we had developed a questionnaire called the PIP-FQ, which was our outcome measure here to see about to understand outcomes and attitudes also. Later, just to give you an idea, later we have had this so-called impact study started in 2012, where we have also expanded our genetic testing profile, done more research, and we have now through our hospitals and other hospitals and other community centers enrolled more than 10,000 patients in the meantime. 10,000 patient genotype, where we have data on their outcome of medication, where we have data on their genetic variation, and so on. So it's going to be really exciting to analyze all this data. And we just recently published the whole study protocol, if you're interested. Anyway, this is just what we're doing here in order to move forward with the implementation of that sort of genetic testing. And we have then also collaborated with a company who has used a combinatorial approach, which means that drugs are certainly targeting multiple targets and receptors and transmitters and whatnot, and they're metabolized also by many different genes. And the ultimate best test was certainly some tests where you would incorporate, like in an algorithm, all the possible combinations of genetic variations, and then basically come up with a plan. And the plan could be, for example, to bin your medications into 3 categories. Yes, you can use them as directed, or you should be more cautious, or you should better avoid it. But if you still want to do this, just make sure that you might do a bit more frequent monitoring, for example. And just to be clear on this, and no genetic testing is meant to replace common sense judgment of any physician. And even if you feel inclined to give a medication where the genetic test might warn you about, it's still ultimately at the physician's decisions and discretion and what they want to discuss and what they feel would be best to the patients. So it shouldn't be replacing. It's not aimed to replace any treatment algorithm or protocols that are out there. It should rather be used as additional information to optimize your treatment. And again, this is one way of doing it. There are certainly more than this one here. But however, ultimately, this is what we all want. This is what we would all be hoping to have: a tool which takes into consideration various genes and also incorporates their interactions. And for example, your CYP26 poor metabolizer and CYP2C19 poor metabolizer, now you really have probably a problem with medications much more likely, which are metabolized by these 2 enzymes, right? So you want to just know about that, and you want to also know what you do in certain combinations. So that's the way to go, and that's a study we're currently conducting. But I'm going to show you here now, just to give you an idea, the 382 physicians who have filled out the questionnaires about how they liked our medication, how they liked our genetic testing whenever they prescribe new medications to their patients. And I'm going to show you here briefly the results. This question was, if you were given treatment recommendations and have taken these into consideration, would you say that compared to baseline, your patient has benefited from the treatment changes? The idea was, we don't want to cause harm to patients. The idea was, if we do include genetic information and now, patients have been treated, would we see that it might actually have caused patients to complain, for example, or physicians to say, no, it didn't work. We may have also creating perhaps false expectations was our worry here. So first of all, as a physician, you always do not want to harm anyone. This is primum nihil nocere. And the results were surprising in certain ways that, we can see that basically these are the outcomes. Anytime we gave genetic information and patients were assessed for a second time or for a third time later on by the same physician, most likely with a predominance of 120 to 2 times, patients improved, and no one, or actually only 2, reported to get minimally worse. Obviously, this is great because it shows there was apparently no harm done, which was our first goal, to understand what happens if you use pharmacogenetic testing. Now, is it a proof that pharmacogenetics is superior to treatment as usual? No, that's not the proof here, but at least it shows, again, that you're unlikely to harm anyone in this situation. And this is what I'm saying here. So far, so good. But however, we would need a different sort of study to evaluate the superiority of treatment. And that's where we started our RCT, randomized control trial, which is called the GAP study. And this is an ongoing study where we are having patients with depression, patients with schizophrenia, and they are prospectively assessed once we have genetic testing completed and given the recommendations to physicians, and once where the physicians could just choose and were blind to the genotypes, which we call treatment as usual, and that will be compared after 12 weeks of treatment, and long-term follow-ups are also included. Cost-benefit analysis will be added, and so on, and this should also then hopefully show us the superiority and to which extent genetic-driven treatment is better than treatment as usual. We have then also included markers for antipsychotic-induced weight gain that we have developed here in Toronto, that we have identified here in Toronto, I should say, and also want to know whether or not using these markers for antipsychotic-induced weight gain can also, be beneficial in treatment upfront. Good. So with that, I conclude the first large part of pharmacokinetics. And we'll use the last minutes to briefly take you through the two other remaining domains, one of which is symptom reduction, therapeutic response, as we've said. And here we have more recently started to conduct some research in late life depression. This is characterized by depression after age of 60, 65, typically. And this is another somewhat challenging condition to treat sometimes because there are more comorbidities now in the elderly, more co-medications, they're more susceptible to side effects many times. So here we also believe that if we could improve treatment by using genetics, we can largely expect benefits. And also it should be noted that depression is a risk factor for Alzheimer's disease. And therefore, treating depression adequately and appropriately and efficiently will also delay or even prevent perhaps onset of Alzheimer's disease in many patients. So that is the breakdown of the study. It's a very, very nice study sample. 350 subjects were treated first 12 weeks with venlafaxine, and it was really determined afterwards if there are responders or not. And if there were not responders, they were moved on to placebo or Abilify augmentation. But the point is here that we clearly had a very good understanding if these patients were responding on venlafaxine or not. And so here is a breakdown of the response curves, and you can clearly see that the blue line means, on average patients, this group of patients, this cluster of patients has not responded very well, has mostly remained more or less in the same symptom severity score. And you can see two other clusters, I would say, even though you can almost group them, but which have shown either, faster response at the beginning, but then a less sustained progress later on, or people who have first not shown much improvement in the first 1 or 2 weeks, but then had a sustained and actually optimal way of responding and alleviating the symptoms. And now we looked at a very obvious candidate, which is the norepinephrine transporter gene, because the norepinephrine transporter gene, the enzyme, is blocked by this medication. Venlafaxine is blocking norepinephrine transport within the synaptic cleft, and we can nicely see that this variation was nicely associated with outcome to treatment. And if you look at the orange line, these are those people who have responded much better to venlafaxine, and they had a genotype which actually affected the expression of the norepinephrine transporter. And that is a nice study, I think, a nice evidence that, or suggestive evidence until further replicated perhaps, but that this gene might play a role in late life depression if you treat patients with an SNRI. And that can be used hopefully in the future to, and added in genetic testing modules to improve treatment. Last but not least now, the last minutes is going to be about side effects, and I have been particularly involved in studying weight gain. Because weight gain is a very severe, can be a very severe side effects with particularly two antipsychotic medications, which are listed here on the left, clozapine and olanzapine, cause on average in adults after 12 weeks 4 to 5 kilograms of weight. And that is substantial, a substantial amount. And keep in mind that some people might not gain weight perhaps even, but some people now gain probably even double or triple the amount of weight in this time. So there's a huge variation, and unfortunately, however, why don't we just then pick lowest risk medications? And it's being done. This is why aripiprazole on the right here is one of the most prescribed antipsychotics at this moment, because it has much lower propensity to induce weight gain, and is otherwise well tolerated also. Unfortunately, when conditions are more severe, more chronic, and treatment resistant, clozapine remains still the antipsychotic, the state of art for treatment-resistant schizophrenia. So the problem is we just cannot avoid using it, and probably 10% of patients with schizophrenia are taking clozapine and are benefiting tremendously about this. Unfortunately, however, some of them gain a lot of weight, and would like to understand more about the mechanism and to avoid it. So we've done a series of studies in the past. We've looked at various gene pathways, and this is just a list of genes we found, list of genes where we found an interesting association with antipsychotic weight gain to be followed up and also to be evaluated. But there's one gene here which I believe is particularly interesting, and that's the melanocortin-4 receptor gene. Melanocortin-4 receptor is involved in satiety and appetite regulation, and there is a gene variant which was also associated with obesity in the general population, and it looks like that same variant, or at least a variant which is in linkage to the equilibrium, which is close by, and does also affect gene expression, if you wish, is very much involved in risk for weight gain, which you can see here on these 4 samples, and each time in each of these 4 samples across the world, it was shown that those who have this AA genotype are at much higher risk to significantly gain weight, and that certainly is a good study result, because you see the replications in different areas with different medications in different patients, and hopefully this gene can be further validated and then included in a genetic risk panel like this one here, which is again a very preliminary study, but based on our study sample, if we included these 6 genes into one panel, and we would test all these 6 genes preemptively before getting treatment, we could nicely distinguish people who have low risk genes or no risk gene variants. They would even on average tend to lose some weight, but those who have more, at least 2 or 3 or 4 risk variants would gain weight, and those who have 5, 6, or 7 of these gene variants, they would actually gain a lot of weight, at least 10% or more. And so that's where we are hoping to go to, building a multi-gene test also for side effects, which can be used independently of any of the other tests, for example, the CYP2D6 test and so on, or in conjunction at some point, but this is hopefully where we're going to. So last but not least then, I would like to summarize. I guess you've all seen and understood the current situation for the so-called phase 1 CYP enzymes and how much they influence drug levels, response, and side effects with many psychotropic antidepressants and antipsychotics. You've been shown that, I guess you get an understanding that implementation is slowly progressing and is more and more adopted globally. Genetic tests might become available, however, also specifically to predict side effects. And this is the group here in Toronto I'm most closely working with, and I would like to thank them, because obviously it's a lot of work here being done, and we're basically having a great team here and a great infrastructure to do many of these science research tests, but also in terms of clinical application and implementation. So with that, I would like to stop my presentation. Thank you so much for your attention, and please let me know if you have any questions. Thank you.
Thank you, Dr. Mueller, for that informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Ask a Question drop-down box located on the far left of your presentation window. Type your question into the box that appears on your screen and click the Send button. We'll answer as many of your questions as we have time for. Okay, let's get started. Our first question is, do you think PGX is ready for clinical application?
Yeah, PGX is the abbreviation for pharmacogenetics, and as you can see, or as you have heard, it is now recommended to use whenever you know your genotyping information, and you are now expected to be treated with medications, which means once you know them, means obviously once you have undergone some way of genetic testing. The question really is, would you like to do it? Would you not like to know it, your genotypes? And here we see that the majority of patients is clearly in favor of conducting genetic testing whenever they know that they need to take a medication. The question really remains, however, who's going to pay for this, and how is information be delivered? And I believe that coming to conclude it, I would think that yes, it is ready for clinical application as long as you do it properly, as long as you have access to a good lab, and as long as you can certainly also cover the cost somewhere. Then it shouldn't be a problem. Now, if you want to, however, be on the more, let's say, reasonable economical side, you can now decide to, for example, give first everyone a chance to respond on a standard antidepressant, which might be safe to prescribe, for example, sertraline, because it does not, it is not so much metabolized by these two drug enzymes. But if it doesn't work out and you now have to give a second medication in maybe half of your patients that you treated, then a genetic test should much more be considered at this point of time, because now you want to really probably look into more details and also would benefit from our information.
Okay. Where should people get tested?
Yeah, that's an excellent question. Basically, it really very much depends on which clinic you might be going to. Do they already offer genetic testing? And there are more and more clinics who do so. But perhaps before you get into treatment, you may want to find out whether or not there is a clinic in your city which does, provide genetic testing as part of your treatment plan. You may want otherwise look up the internet. You may want to perhaps also have a discussion with your insurance company if they would reimburse that, because some insurance companies do reimburse testing, and they might have collaborations with certain partners, and then you could follow their advices, and certainly you're free to meet with your physician and discuss it with them, and they might know ways of how and where to do it. And ultimately, you can also collaborate with a physician, and you can also suggest them to help you get the genetic testing done, because in many times companies will like to have and report results to a physician rather than to patients directly. And therefore, you should perhaps speak to a physician and see what they know. You should do some research, find clinics in your city, talk to insurance companies, and so on. And ultimately, that would you should be able to find a good plan. And again, there is research publications who also list centers. Otherwise, feel free to connect with a researcher like me, and we're happy to assist and hopefully can find some ways of where you could ideally find your genetic testing lab.
Okay, and we have time for one more question. what genes should they look at?
Another excellent question, and I think that we have heard in my talk here that at this point of time, if you really go by conservative means, if you really follow science and research data, there is two enzymes for drug metabolizing purposes. You want to know for sure. This is 2D6 and 2C19. Then you may want to consider HLA in case you have in case you might be an Asian and you are potentially looking into carbamazepine treatment. These are I would think under most conservative standards the genes you should absolutely look at, and at this point of time the best evidence is for these two genes with psychiatric medications. The other ones are not necessarily useless. Other ones that can include other CYP enzymes and so on. But again, the level is lower, and the information, the actionable information, might be just less, and might be more basically a bit more experimental at this point of time. But it is important, of course, to conduct research and to also find the right balance between a standardized treatment and like where you have a good evidence plus combining it with genes which are still more under investigation in order to allow also for more research and for a better understanding, so that in the future we can expand the gene lists much more and with much better confidence and much better evidence. Yeah.
All right, I would like to once again thank Dr. Mueller for his presentation. I would also like to thank LabRoots for making today's educational webcast possible. Before we go, I want to let everyone know that today's broadcast will be available on demand viewing through September of 2018. You'll receive an email from LabRoots letting you know when this webcast will be available for replay. Please share that announcement with your colleagues who may have missed today's live event. That's all for now. Thank you for joining us. We hope to see you again soon. Goodbye.